I'm going to introduce our next speaker, Karl Pfleger. Karl's been involved in a lot of efforts to address aging, and he's been supporting a lot of companies in the Bay Area. And I just want to also say we need more Karl Pflegers out there to support more companies, because basically those, So there are people that make the seeds and put them in the ground, but they need a lot of water. And Karl's basically helping us water those plants so they can grow and make some wonderful things. So I just say thank you, Karl, and I'll give the microphone to you. There you go. Okay.
All right. I want to say, Lawrence, I think that, and with apologies, Steve, but I think the Apollo program's better than the Manhattan Project, because it's 12 years plus, and it didn't kill people at the end. And I'm not just saying that because my PhD's from Stanford. Okay, so as you know, I'm Karl, as he said. I'm Karl, as he said. You can find me on LinkedIn and social, and I've been an investor, as was discussed. So, just so you understand my conflicts, they're on my specific investments are on LinkedIn. These slides are going to be dense. Feel free to scan this code, or just tinyurl.com Karl 2026, and those will be up at the end too, if you want to just decide then. I founded agingbiotech.info. In addition to investing, I run that site that tracks the commercialization progress of the field, and really it tracks everything in the biotech, aging, and longevity sector between academia and the clinic. And that gives me kind of a unique bird's eye view of the field. And so I'm going to give you some of the benefit of that bird's eye view now. And so the talk today is going to be about eliminating aging, and it's split into 3 sections corresponding to this title. So we're talking about motivation, which will probably be familiar to a lot of you, but maybe there'll be a few new tidbits in there. The status, which is a message I've been talking about for the last year, but it's an important one, and I think a lot of you probably haven't heard it in this audience. And then what I think is the path. And so those will be 3/3 of the talk. First third, motivation. So, we know in 1900 or a long time ago, all the way before that, infectious diseases were the top causes of death, or at least half of them, and the top 3. And of course, since that time, now aging is the direct cause of the 9 of the 10 direct causes of most death of humans. And a lot of the infectious diseases have been largely eliminated, which is great. And it's if you think about before 1850 or something like that, I don't think anybody in the world really thought that was even feasible. And then in 1900, maybe the scientists who were learning about germ theory, but the massive public probably thought that was kind of a fanciful idea. So I'm not going to try to. I'm trying to not spend too much time on these motivation slides, but everyone kind of knows the capsule history of medicine. The important part I want to focus on here is it sort of starts with the observation of obvious disease at the end, and then we figure out some causes of that, and then sort of sometimes you then figure out a cause of one of the causes, and then you kind of backward chain a little bit, and that happened for decades in medicine, and we make interventions against Z, and we make interventions against a more upstream version sometimes. And what's happened in the last 50 years that's different is that this sort of science of aging has come along, and we've backward chained to the point where we're finding these important pieces that underlie multiple different of the causal chain pieces for different individual age-related diseases. And so we have this thing called, so the idea is, maybe we can interfere in one of those earlier step things that then will actually feed forward and mitigate multiple age-related diseases. And we call this the geroscience hypothesis, the belief that we can interfere with some of these early stage shared core aspects of aging. So we just sort of label all those things. Those not only cause these age-related diseases, they cause these other characteristic aspects of aging, gray hair and everything else that goes wrong with aging. And so we call that the geroscience hypothesis. We can interfere with those and interfere with multiple. And that's sort of the North Star of the field, right? That's like, for a long time, has been the sort of main thing that ties the whole field together, and why we think it's a better approach than traditional biopharma and traditional medicine. So you've seen, everybody's slides have some version of this generally. Aging's the top risk factor for the chronic diseases, but the funding is terrible. 85% of people in the US die because of aging, but it's less than 1% of the NIH budget, et cetera, et cetera. And look how much of a tragedy it is. It's equivalent to many COVIDs a year, a World War II every couple of years, and plus there's this economic rationale for solving it because it's massive. Even just a 1-year delay in aging is worth trillions of dollars. So recently, some of you may have heard there's an upcoming edited volume coming out from Springer Nature. I wrote a chapter for this volume, and the chapter I wrote is basically summarizing the reasons why we should solve aging. And then the second part of it, which is actually the bulk of it, is the latest iteration in a long line of academic work. Aubrey's no longer here today, but he sort of started this in the 2000s, talking about solving aging, and then people have all these objections like boredom and long-lived dictators and overpopulation. And it turns out that smart people have thought about all these problems and gotten good counterarguments. And so I wrote this book chapter, which is now available as a preprint. So you can, if you go online, use that QR code, you can click on the links all the way through this presentation, including to this one, or you can find this chapter pretty easily on my social media. But this summarizes the best counterarguments. It's sort of the comprehensive view of the idea of the counterarguments to these common objections. So everybody feel free to use this in any online social media discussions or offline discussions when somebody brings up any of these objections. This is a one-stop shop to link to sort of show them why overpopulation is not a problem, why long-lived dictators, this is a terrible objection. And it turns out I synthesized these into sort of 7 different categories, and there are 43 different objections to the 11 most common, or 40 counterarguments to the most common 11 objections. It's all organized. So last sort of high-level point, right? Less aging causes more longevity. Aging is the pathology, longevity is the side effect of mitigating that pathology. It's a little bit of a chicken-egg thing. Many of you are probably familiar with the cognitive bias in humans, very prevalent, that loss aversion is more salient than gain. And so people are much more averse to losing X amount of value than they are to potentially gaining that much value. And so I actually think it's a problem that so often the field goes by the label longevity rather than the label aging. It makes the field sound greedy. We're trying to get more of something rather than just we have this pathology, we're suffering from this ill, and we're trying to cure it or mitigate it. If you look at the analogy to cancer, as I do on the table at the bottom, right, cancer is the pathology. And how do you measure survival? You call it something like overall survival. But the way the field is referred to commonly is still cancer. And it's the National Cancer Institute, it's the hallmarks of cancer. But if you look at aging, it's the hallmarks of aging, it's the National Institute on Aging. But for some reason, the common vernacular, the common lay term for the field is longevity. I think this is probably an error in messaging. I personally like to focus on the pathology. I'm trying to mitigate aging. Aubrey's been saying this lately too. He's interested in health, not in longevity. This avoids the problem of talking about health span versus lifespan as well. Just don't talk about spans. Just talk about aging and its ills. Okay, so that's the first part. So the second part, I started giving a talk about a year ago that's titled here, FDA approvals of aging therapies have started and more are coming soon. This is a weirdly absent narrative in our field, and I don't know why. There's a 14-minute, I'm going to do a sort of a 5-minute version of that. There's a 14-minute version I gave at Vitalis Bay a year ago, and half a year ago I gave a 20-minute version at the Buck. You can click on each one of these. They're both up on YouTube. As I said, I'm running agingbiotech.info. It has a list of all the companies. It's a great resource, so you should check it out. But I've been tracking that for over 5 years now, and so the important broader history to know in the upper left-hand corner there is that if you look at when companies that focused on aging and longevity were founded, it was really not till the late 2010s. There's been decades of research in this field, but the academics didn't really translate into a measurable quantity of biotech companies trying to translate that research until starting in the late 2010s. It takes about 10 years to get the FDA approval from starting a biotech company at least. And so, well, it's about 10 years from that beginning of that real upswing on the upper left corner, graphing the number of companies founded. So we should only just be expecting things. So every now and then you'll hear narratives in the field like, oh, the longevity biotech approach has failed because there's no FDA-approved treatments that lengthen human longevity. Of course there aren't. There's only been 10 years. We're just sort of getting started. And there are approvals that totally embody the geroscience hypothesis. So in the last 5 years, amount of funding total to the companies, employees, number of clinical trials, it's all up and to the right. But it's not quite like super exponentially up and to the right because of lack of funding. But let's look at the late stage clinical pipeline, which I can do from the data on that website. So skipping supplements, skipping diagnostic companies, skipping veterinary, pet-directed, just focusing on humans and human clinical FDA trials, there are a half a dozen things that have gotten to approval that target core aspects of aging. They target some core aging pathology that underlies multiple diseases. There's another couple in regulatory review where the phase 3 data's come in and it's been positive, but they haven't gotten their FDA approval yet. But that's highly likely, 90+% likely. There's known statistics on chance of FDA approval at different stages of the clinical phase 1, 2, 3 cycle. And then there's another almost 15 in phase 3 with a greater than 50% chance of approval, which means we should expect that there's going to be another 7 or 8-ish approvals in the next few years. And then you can sort of backward chain back. The phase 2s, there's almost 40 in phase 2 now with a smaller chance of getting to approval, but that should create another trickle after the phase 3s, whichever ones succeed. And then there's a huge number back in the preclinical. There's, at least 60 in late stage preclinical where they've raised several $1 million. And so they should be in phase 1, the ones that succeed to get to phase 1. It should be in a couple years. So you can kind of see, of course it's harder to predict the future farther in advance, but there's approvals happening and there's clearly a steady trickle coming. So this is pretty hopeful, I think. I mean, it's slow. There's not, this pipeline needs to be massively parallelized and expanded, but it's not that there's nothing happening. The model is succeeding. So I went through by hand and looked at the phase 3 trials. And I said, okay, I can see that this company's in phase 3, but is it really an aging therapeutic? And does it really embody the geroscience hypothesis? What is the likelihood that for whatever clinical indication they're going through phase 3 trials for, that it's likely to label expand, that the target and the mechanism of action are likely to impact other age-related diseases as well? And I by hand looked at all the companies with phase 3 trials, and these are the targets and MOAs, and obviously they really are going to label expand. Most of them are things that are like key central aspects, like FGF21 or mitochondria, stem cells, and so you can go through the details yourself if you want, but these really do embody the geroscience hypothesis. And so this is quite different from traditional biopharma. If you want to go and look in more detail with links to clinicaltrials.gov, there's a table on agingbiotech.info called trials that you can go look at the details. So this is important because it really shows that the model, and these things should all basically be pipeline in a pill or product in a pill if it's not a small molecule, pipeline in a product if it's not a small molecule, as Juvena's slides like to say. So I'm shocked that this isn't discussed more, right? This is not what Peter Attia and Brian Johnson talk about. It's not what most discussions about the field are about. But this should be on the radar. Okay, so for the third part, I want to just talk about something I've been thinking about a lot more lately. There really are two almost completely separate or pretty separable longevity fields. And people don't discuss this enough. There's sort of a third distant cousin, which is the whole body replacement. Take your brain and transplant it into a young body. That's kind of a pretty distant cousin with different technologies involved. So I'm not going to talk more about that today, but it does have a number of positive properties, but it's also very, very small compared to either of these other two. Most of the field is broadly slowing aging, calorie restriction, rapamycin, et cetera. But there's this whole other field, divide and conquer rejuvenation. And they have very different properties, and a large fraction of the field is actually implementing divide and conquer rejuvenation. They're implementing one piece of it, but hardly anybody other than Aubrey ever talks about that as a high-level strategy for the whole field. And more people should recognize this as a sort of valid subfield or separate field in and of itself. And there's a couple litmus tests for how you distinguish these two fields. And very few people talk about the two at the bottom, which I'm going to go into detail on, which I haven't heard even Aubrey sort of clarify. The high-level thing is, are you solving all things with a monotherapy, like calorie restriction, which seems to retard all the hallmarks of aging with a single monotherapy, same with rapamycin, or are you targeting just one core aspect of one particular subpathology? And that's the sort of main distinction, but these other distinctions follow from that. The slow aging approach doesn't tend to have effect sizes that are huge, whereas the targeting individual pathology, you can really just solve the pathology completely. But the two interesting things that really distinguish it are targeting a process versus a stable structural target. This is the real key distinction here. And the second thing is whether or not you need to keep applying therapy, sort of continual dosing, versus whether it's something you can do and then wait many, many years before you have to do again. And so we'll talk about those. But so what I'm going to essentially do now is talk about this top distinction, part versus all, and then talk about the process versus structure after that. So part versus whole, which is actually the goal? There's this sort of misconception because of the way we do science, the way both academics study things and the way biotechs do things, is they tend to do one therapy at a time. As a result, they tend to test one therapy at a time. And because the label longevity, people focus on this lifespan idea. Well, the only way to make a meaningful impact on lifespan with one therapy is to broadly slow all of aging. So a large fraction of the field focuses on that. But that's not the only conception of the field. There's a post here you can read in more detail about what counts as a longevity drug, which is a discussion that's come up a lot since the GLP-1s. But anything that embodies the geroscience hypothesis is one valid interpretation of what should count as a longevity drug. But lots of things embody the geroscience hypothesis but don't extend lifespan by themselves. And that doesn't mean that they're not part of the aging field. So the process versus structure thing is something Aubrey's been talking about for a long time, but hardly anybody else. And he phrases it a little differently. So this is the classic Sen's Aubrey slide, which he put up a version of before. I've changed the inhibition line on damage to emphasize that it's actually reversing, not just inhibiting the damage. But we can take the language of this talk and impose it on this classic Sen's diagram, right? Metabolism is a process, right? In biology, which is basically chemistry at the bottom, right? Things are either stable to stable structures, or things are the chemical reactions, the processes that operate on them. mTOR is pathways, and things are processes, and metabolism is a giant, complicated process. But the way it mediates aging is that it creates stable molecular structural changes that change in characteristic ways that are embodied in the three-dimensional structures. And of course, the processes and the structures really have a feedback loop, but the key idea behind divide and conquer rejuvenation is to target the stable structures and reverse them back to the states they were in, equivalent to much younger, many, many years earlier states of life. So you can do things like take the hallmarks of aging, or the 7 Sen's areas, or the pillars of aging, the 2024 Kennedy paper, and you can categorize which of these are really targeting structure versus which of them are targeting process. And of course, the 7 Sen's areas were designed by nature to target structure, so they're all structure. But a lot of the hallmarks target structure, and a lot of them overlap with the Sen's areas, but some of them really target process, like metabolism or intracellular communication, chronic inflammation, etc. So this is also a table on the site, categories, and this also usefully maps between the Sen's areas, the hallmarks, and the pillars. So drilling down into what the actual structural things are that embody aging, right? It looks a lot like SENS areas, but SENS got a few things not quite right or didn't anticipate certain things. So it's a broader set than the ones on the left here, and this isn't exhaustive, and this is the SENS areas plus a few other things. But then each one has specific sub-areas. So for example, there's many different kinds of senescent cells, there's many different misfolded proteins that play pathological roles. The cell loss or tissue atrophy or tissue loss has many different examples, such as the loss of the particular cells in Parkinson's disease, et cetera. And there are many programs in clinical trials addressing many of these, but not all of them. And of course, to fully solve aging, we need to solve all of these essentially. But possibly, and this is the thing underlying Aubrey's current LEVF, possibly solving a large fraction of these could actually get us far. And even just solving one gets us mitigation of multiple age-related diseases. And it got the diseases mapped on the right. What nobody in the field is doing is mapping this out in much more detail and seeing which ones have clinical programs, which ones need more research areas. That's something that the field should be doing as a whole and not just me by myself. So which one do we care more about? Slowing aging broadly with monotherapies or divide and conquer rejuvenation? So, you know, to a certain extent, the biggest problem in the field is the lack of funding, and anything that increases the funding is good. There's a table, here's a list of 15 things that increase funding for the field. A lot of them are slow aging. That's fine if it works and it really increases the funding. There's a table called convincers on the site. You can dig down in more detail. But broadly speaking, you know, the trade-off here is the things that broadly slow aging are great because they hit all the different subpathologies of aging, but their effect sizes are lower. But that's where most of pharma dollars are drawn right now, because those things mitigate the age acceleration caused by modern lifestyle, including obesity. But divide and conquer rejuvenation is the sort of default path to really fully eliminating aging if that level of effect size is the real goal. Because that's how we can actually fully fix each of the pathologies. It just takes a whole lot of them. And with good biomarkers, you don't need a high N, unlike for the slow aging. You don't need high N to show that you've really killed all the senescent cells if you have a good senescent cell clinical diagnostic. So, you know, you have to think to yourself, which one of these, how should the field divide its resources between these? So that's it. Here's the take-homes. The thing I most want you to remember is that broadly slowing aging is sort of a valid subfield, but so is divide and conquer structure targeting rejuvenation. And that's always think about which subfield things in the field break down into. You know, the process versus structure division and I didn't really talk about the administration, but infrequently intermittent dosing is the key aspect of the structure reversal. And that's it.
Thank you, Karl. That was a great talk. I'm going to go out there. Yes, we have questions. Yeah, absolutely.
Yes, thank you very much. That was a phenomenal and thorough overview, and I appreciate the dose of optimism you provided about approvals on the horizon, as well as the tabular compendium of responses to common arguments of skeptics. Now, I'm curious about the rhetorical turn that you suggested to focus on aging rather than longevity, and of course, that focus has been in existence within the field. The field has been called anti-aging, at least certain segments of the field. But some people have this confusion between chronological age and biological age. And of course, we know what we're talking about when we talk about addressing aging. But a lot of people think, well, chronological age, it can bring wisdom and life experience. And I myself would like to have the wisdom of a 150-year-old in the body of a 20-year-old. So all of us would. Perhaps, I know the term senescence is more technically correct, but a lot of people don't know what that means. Perhaps a term like decrepitude may be a good one to use. Maybe we should bring that back.
I guess the message is important. How you say things is important. Karl.
Yeah, I mean, there's lots of reasons why the word aging has problems. The anti-aging has a bad rap because of snake oil, and like you say, there's a confusion with chronological age. And there's plenty of good specific discussion in that preprint that I linked about why wisdom and the other positive things that come along with living a long time are really the result of living, not of aging. Adult biological aging and its degeneration are not in any way necessary for those benefits. Yes, so all labels are imperfect in some ways, and my point about aging being the pathology versus longevity being the side effect applies regardless of how you name the pathology. And there are very good reasons why aging is a much better name than decrepitude or some other things. But I'm not going to argue that case here. I mean, you know, I just want people to recognize the negative side effects of saying longevity. It makes the field seem greedy. And I think, for example, if we focus on aging and on aging pathologies, and I like to use the term aging subpathologies. Aubrey tries to use the term damage, but I think that's confusing because in some cases the damage is really just tissue a stem cell exhaustion or something like that. But focusing on aging pathologies really gets rid of the whole billionaires living forever greedy kind of character. You can't characterize the field that way as much.
Thank you. Yes, we have another question here. Yes, it's definitely important how you say it, because the words are important. All right, yeah.
I think we are ignoring the most important things in aging, and that would be, for example, the developmental exposome, the consumption of sugar, when was the last time you saw an advertisement for Brussels sprouts? But meanwhile, we're pushing, we're pushing expensive drugs, and that's all you ever hear about. That's all I've heard about here. It's not really acceptable. Massage, and what about, and it's not, going over to Honduras is not an accessible solution. We need something that everybody can get. And that's enough. I could go on.
Yeah, no, absolutely. Like promoting a healthy lifestyle, that's a no-brainer, right? I mean, that's definitely going to help you live longer, and a lot of other very, very simple things that we can do. But go ahead, Karl.
Okay, so first of all, let's take you to the two things you said in turn. So development. When I say aging in this talk, and this is a short talk, so I didn't have time for all the normal caveats, but if you read for example, the preprint of the book chapter, it makes this point very clearly. When I say aging, I mean adult biological aging. I don't mean at all anything that happens before adulthood. Things that happen in development may affect the biological state that you start adulthood in, and that's just part of the variability that individuals have, just like the variability they have from their genome. But it doesn't matter what happened in development or what your genome is, we all still age. Every single one of us, as long as we made it through development to adulthood, still ages. And so there's a bunch of shared processes that degrade biological adult state, and that's what I think we should target. Those are the aging pathologies that we should, a whole separate topic is people should have good development and we shouldn't be sabotaging ourselves there, but that's sort of a separate thing. Eating Brussels sprouts, not eating sugar is just part of healthy lifestyle. Lifestyle affects the rate of aging because it affects a bunch of these processes, but it doesn't matter what that rate of aging is. You can have the healthiest lifestyle possible and you're still going to age. And if you deviate from that by eating more sugar and less vegetables, you're just going to speed that process up. And of course, what the metabolic targets and tweaks and what a large fraction of the longevity industry focuses on, including GLP-1 drugs and probably including rapamycin and metformin, is simply mitigating the age acceleration of those tweaks from optimal lifestyle. And there's no evidence so far that any of those slow aging interventions actually bring you to a point where you're aging more slowly than you would if you had the optimal lifestyle. And the lifestyle is more like evolutionary. But yeah, I absolutely 100% agree with you that those things are super important. And one of the reasons it's super important to optimize lifestyle in order to slow rate of aging as much as possible is because you want to live long enough to see the breakthroughs in these other rejuvenation techniques.
Exactly. So obviously, a healthy lifestyle is super important because if you live that extra year and live long enough to perhaps maybe have one of Karl's companies come through and get that drug that will make you live another 5 years, and then after that another 10 years, it's that escape velocity, right? If you can get to that point where you can kind of push it a little bit more, and a little bit more, and a little bit more, then it's worth eating Brussels sprouts. Or, what's that? And there's, yeah, exactly, a little bit of butter and, exactly right, yes. So anyways, okay, so just FYI, people ask me, what they should do, and it's pretty simple right now until there's, verified therapeutics that can extend life. I say, try to be happy, try to eat right. Yes, Brussels sprouts, broccoli, whatever, fine. And, exercise moderately and just the basic stuff, okay? And don't really go crazy on anything else, just the basic stuff. But obviously, Karl and other people are working on actual therapeutics to extend life. And again, Karl, thank you so much. Great talk.
Let me make a quick comment.
Yeah.
When I was at Google, Walter Willett, this is a talk for you. When I was at Google, your namesake, Walter Willett, came and talked. Walter Willett is one of the top 5 cited authors in all of medicine and clinical science. And so he's one of the world's top experts on nutrition. And he came and gave a talk about all his massive data sets on tying health to what people eat. And he said, it's just massive how important vegetables consumption correlates with health and whatever. And he said they've gotten at the point, this was maybe 10 years ago, but he said they'd gotten to the point where they had such massive data now they could start digging into like individual foods within classes. And he said one of the most interesting signals was that Brussels sprouts actually, plants, why are plants healthy? One of the plants, it's a hormetic effect because the plants have these chemicals in them they're trying not to get eaten, right? And he said it's actually funny, if you eat, the people who eat the most Brussels sprouts actually start to have negative effects from them because the Brussels sprout, the chemicals in there, the defense chemicals are actually so concentrated that he actually determined a negative Brussels sprout signal at doses that normal people actually eat. I still eat Brussels sprouts, but I don't go crazy.
Okay, if you don't learn anything here, 1 word, 2 words actually, Brussels sprouts, okay? One last thing, Karl, actually, this is actually serious now. Sleep. Right? Sleep is unbelievably therapeutic and high quality sleep, okay? Make sure your room is, and I tell this to everybody, make sure your room is dark. I mean dark, okay? And cool, and make sure you have a good, your mattress is your best investment for longevity, believe it or not, right? If you want to live long, get a good mattress.
Diet, exercise, sleep, avoiding deficiencies, and avoiding smoking and abuse of
What he said. All right, thank you very much. Thank you, Karl. One more time for Karl. Thank you, Karl. All right.